Good morning, everyone. Happy third day of hymns, or fourth or fifth, depending on when you got here. I'm Jacob Ryder. I'm a family doctor and was Deputy National Coordinator at that little office of the something or other a number of years ago. And currently, I am the Chief Executive Officer for an organization called the Alliance for Better Health in upstate New York. We are a bit of a Medicaid ACO, to translate in 90 seconds or less. I'm a member of the HIMSS Innovation Committee, and therefore am introducing the speaker today, or the host. So welcome to the exciting Views from the Top session titled Welcome to the Age of the Patient, Transform Patient Relationships with CRM. On behalf of HIMSS, it's my pleasure to welcome you today to this Views from the Top session. We're pleased to have you here with us today and would like to extend our thanks to Salesforce for their continued support of HIMSS. HIMSS strives to provide attendees with compelling education opportunities by including some of today's most cutting-edge and disruptive companies in our programming. I'll go off script and say, and Salesforce is that? During today's session, our speakers will explore how to bring people, processes, and clinical administrative data together in a unified platform to improve care team productivity, reduce unnecessary use, and serve populations at scale. It's my pleasure to introduce my friend and fellow family doctor, Josh Newman, who's the Chief Medical Officer of Salesforce. Please join me in extending a warm welcome to Josh.
Well, hello, everyone. Thank you so much for coming. As you can see, I have a day 3 HIMSS voice. And it's a pleasure that you guys all made it up so early in the morning actually it's day 4 now, to come and join us, so thank you. It's really a privilege to be here. Today we're going to be talking about how to transform patient relationships with CRM, and for those of you that might not know, CRM stands for Customer Relationship Management. And so the goals today are really to figure out what is CRM, how is it used in healthcare, what are some of these forward-looking organizations doing as they think about this, and solving these problems. But I have another agenda. CRM is really based on cloud-based systems and modern architectures and modern technologies. And so much the same way that the Wizard of Oz goes from black and white to color, we're talking about transformation from older technologies to newer technologies. And so we're going to evoke that same motif and go from black and white to color. So welcome to the age of the patient. And you'll notice that a bunch of other names are coming up there. The age of the citizen, the age of the consumer, the age of the shopper, and how we transform those relationships. Now, many of you may be providers. How many in the audience are doctors or nurses or folks that have treated patients? First of all, thank you. You know, for those of us who've taken care of patients, it's always been the age of the patient. And so I'm not talking about what it means for an individual. I'm speaking about organizations and technology systems, and I believe it's unarguable that those systems and the organizations have not really put the patients first. They have not put the patient experience first in the ways that we see in every other industry. And so today it's really going to be our goal to talk about how those CRM systems can deliver the same kinds of experiences to patients that we deliver to customers and shoppers and citizens and all of us. And the really cool thing is that we all enjoy those benefits, and so it should be pretty easy to understand all of this stuff. So I want to thank all of you. You know, healthcare, unlike many other industries, has all of us working together. And as I've seen how HIMSS gets put together by a whole army of folks, as I've seen how people in our company have all worked together, I'm continually impressed by the fact that we all work together, the pharmaceutical companies and the payers and all of you, the providers, all working together on the same goal. And that goal is tough, and there's not a ton of cash overflowing, and there's not the best systems and the best technologies that we could imagine. It takes time, and it takes a lot of effort, and you all work very hard. And the ultimate goal is the health of each other and our citizens and people around the world, and it's really important, and it's really valuable. And for all of you that have decided to wake up early in the morning and come and hear us talk about CRM, it shows a commitment to some of these things, and so I really am genuinely grateful for all of your work. And so, what gives us credibility to talk about this? Well, I work at this company, Salesforce, and we've enjoyed a great deal of success, again, from a lot of hard work, but also because I think we're doing the right thing for a lot of folks. And what we've seen, and we're very fortunate to be recognized, but I think the take-home message here for this slide is that the world really wants this because it works. Whether it's in the financial services industry or shopping, or fortunately for all of us and our patients in healthcare, it's really happening. And we see it more and more, and we've seen and we've heard a number of different organizations that are really taking this on as an important challenge. Every year we see different sort of themes at HIMSS, and I believe consumer experience and patient experience is one that we haven't heard as much as we hear this year, which is fantastic. And so I keep talking about how we're borrowing these mechanisms and these thinkings from other industries, and you all have experience with these brands. I'll point out Uber and Amazon because to me they epitomize the variety of different systems that all come together to provide that experience that makes us all love them and use them. If you have any doubt about that, just walk out to the front lobby at the end of the day and see how many people are waiting for their Ubers. And it sort of works. It sort of works no matter where you are. Or Amazon and how they know what we want to buy. And all of these companies that we appreciate, that we enjoy because they give us the experience that solves our problems without us having to work as much as we may have worked in the past. But CRM is different than it used to be. Many of you may think of CRM as sales automation or Salesforce automation or something like that. And maybe that's what it was 18 years ago or a long time ago. But it's changed over time. So it started with sales, and then customer service, and marketing, and mobility, IoT to bring device data, and all kinds of other data that you'd never had before, and then the analytics to figure out what that means. And now really systems of intelligence and machine learning and deep learning. And our experience has been that CRM is not just a simple task or a simple capability or functionality. It's really this whole range of things. And you'll see some of this. So at the top level, you see the transition from cloud to social to mobile and IoT and AI, the big categories. On the next layer below, you see some of the more specific functionalities. And the layer below that are a bunch of sort of logos of our brands and our products that we've had over time, just to show the progression. And I don't know if we had the vision of all of this at the very beginning, but over time, we've kept adding all these things, and we're finding all kinds of customers around the world using these systems in this exact way. And so why is this important in healthcare, you may ask? Well, as you all know, healthcare is complicated. And what I like about how this slide represents the story is the dotted lines sort of indicate that the relationship between a patient and a caregiver or a pharmaceutical company or a payer or a med device company is not simple. It's not linear, and it's not always so fluid. It's made up of a lot of discrete steps. Each of those steps represents an appointment or a question or a problem or a concern or something that didn't work out well. And how are all of those problems solved along the way? It's not simply what we all used to get paid for when I was practicing. It's not simply writing a prescription or doing a surgery or taking a picture of someone's knee with an x-ray machine. It's all of the stuff that happens before and all of the stuff that happens afterwards. It's really important. And so I'd like to offer a rubric, a way of thinking about these patients and a way of thinking about these journeys, which is essentially a journey. We think about this all the time in our company and with our customers outside of healthcare, and I think it's about time now that we think of this inside of healthcare. So if you imagine the journey of an individual, and we all have these journeys, and these journeys start at before birth, actually. My son's 1 year old. He was a patient even before he was born because we had little pictures of him in 3D. It's pretty cool. All the way. And every one of these little blue boxes that you see, the discrete examples of procedures and clinical services for which providers get paid, every one of those has wrapped around it a whole bunch of other stuff, just like I was telling you. So we're exploding now from the mammogram story, and we talk about what happens before the mammogram. There's a family history. And the other thing to note is if you notice the little sort of accessories that are coming off of this, every one of these experiences have data. There's usually some revenue connected to it. there's an experience connected to it, there's travel connected to it, there's understanding and education connected to it. Just collecting this data is not always easy. And then there's an encounter with the primary care physician. And then there's an encounter with a call center to make an appointment. And then there's an encounter with the technician who actually does the radiology itself. All of these things require coordination. All of these things require communication. If the radiologist is in a different facility, there's all of those complexities. So you can now start to see that some of the pieces that have either been neglected or been supported with analog technologies or paper or whatever people came up with, they can do the job, but they can't do the job as well as we all need it to do. And so I'd like to offer a checklist. And it's complicated, interestingly. There's a lot on this slide, but let me break it down into a few big buckets. The first two are about bringing data and people together. The second are being able to deliver it across any channel and on any device. The third is what the patients sort of live, and this is the patient journey. So it's the care plan that guides them, and it's not just a clinical care plan. It's also a non-clinical administrative care plan, as well as the patient engagement tools. How do you know what someone's experience is? You got to ask them a survey. You got to reach out to them. You got to communicate with them. And then finally, the thing that enables this whole thing to be a continuous learning loop are the outcomes and the analytics that measure, did it work? How well did it work? And what can we do better? I would propose that this checklist, these 7 boxes, sort of indicate a certain kind of range at a certain level of the kinds of things that your organizations should be thinking about or could think about to start building these journeys and to start delivering the kind of care that we all hope to have. Now, you might ask, how or why should you invest in a patient-centric future? And it's a laden term, obviously. All these terms are laden. But let me talk a little bit about whether this is even happening in the first place. IDC, which is an analyst organization, very well respected, did some study of a bunch of healthcare providers to find out where people were investing their money in health IT. And they found that 32% of them were investing in CRM, specifically in customer relationship management, to reach out to folks, to bring them in, to give them a positive experience. But it doesn't end there. If you now start to include the other kinds of components that are related to CRM, you see the analytics and the patient engagement solutions and the experience strategies add even more value, even add more momentum to these kinds of CRM efforts. And then if you want to add all the different technologies that touch a patient's experience, it's the majority of the top 15 bars that you see in this study. So CRM is important. People are investing in it. I think it's never been as important as it is in healthcare. When I first got to the company 8 years ago, I'd never heard of CRM before. I didn't know unwittingly that when I was writing down the names of the patient's family members and their hobbies, I was doing an old analog ink and paper copy of CRM. But really, it's happening, and it's happening more than ever. And so I've talked a little bit about what is CRM. I've talked a little bit about how people are thinking about it. Now it really gives me a great pleasure to bring up a good friend and colleague, John Halamka, who's going to talk a little bit about why. John, please give him a warm welcome.
Thank you.
Thanks, John.
And of course, this is the, am I on?
I think you're on.
Okay, can you hear me now? This is my HIMSS Day 4 voice. 42,000 people, I've met 41,999 of you. Good to see you.
That's right. So John, tell us, why are you seeing people interested in CRM? What are the pressures that are guiding them towards these kinds of technologies?
So I am from New England, and I am here from your future. Today, 70% of my business is not fee-for-service. It is global capitated risk. It is keeping patients well, happy, and satisfied in their homes. And that is an entirely different kind of IT platform. So if you look at the EHRs, they are transactional systems that gather data for billing and regulatory compliance. Do I, as a doctor, have any idea how to keep you healthy and happy in your home? Not so much. But now I'm being paid for quality and outcomes, not for quantity and the visits that you make to a doctor's office or hospital. So I need to completely rethink my approach.
So you mentioned the EHRs, and you have an illustrious history working with the presidential administrations of the last two presidents on meaningful use, on those regulations, which really did focus a lot of energy on the EHRs. Right. Can you talk a little bit about how that shift has happened and how the EHRs might not be delivering this kind of componentry?
Sure. So if you think of Dr. David Brailer in the earliest of days said, oh, let's digitize healthcare, go from your analog paper-based world to a digital world. He didn't really tell us how, just make it digital. And then start to share data and engage patients and families and do a bit of population health analytics. So that was the trajectory we started in 2004, and all the meaningful use regulations took us down that path. But it didn't anticipate the idea that the patient is now a customer. That we now need to focus on all the data the patients and the families generate and their care preferences, and how to actually look more holistically at their continuous health experience, as you showed, and be a part of that with new systems, treating them as all of us would want to be treated. EHR, transactional data, gathered for compliance. This new world, patient as customer.
So we're both physicians, and we come from a long history of conservative culture, understandably, and a whole system that changes pretty slowly. And so when people see the array of different CRM technologies, it could be daunting in the same way that EMR took a long time to really penetrate the market, and it needed a lot of stimulus, as you know. What kind of things, how should people be thinking about how to start adopting these things, given such a broad range of technologies and really stuff that's sort of alien to the healthcare industry?
So if you spend your 14,000 steps today, because that's what you'll walk on the HIMSS floor, you'll see big data, big data, big, I have no idea. What is big data? It's starting to transform into this idea of care management once you have the data. So assume you've spent the last several years of meaningful use gathering the digital information. You can now turn that data into wisdom. And therefore, how do we at Beth Israel Deaconess do that? We define care management as a cohort of patients based on some criteria that need certain services based on a guideline or protocol or pathway. So the new tools, which everything we do is cloud-based these days, who wants to run data centers, is, oh, you have diabetes. That means you need a hemoglobin A1C. You need an eye exam, a foot exam. You need glucose less than 50. So let's actually have care traffic controllers. Not doctors, people who are looking at your continuous experience to ensure those things happen. It's a lot of different vendors and a lot of different products, but think of the tools that you need for that kind of care management experience.
You know, you mentioned that you are doing a lot of work internationally, and we, for a long time, have been talking about in health services research how different the United States is from the rest of the world. Can you give us some sense of how the rest of the world is thinking about this and what their pressures and how they're thinking about solving the problems?
Sure. So we spend 17 to 18% of our gross domestic product on healthcare, which is twice as much as most Western industrialized societies. But yet, every society is seeing the same kind of issue. Aging population. Fewer folks paying into the healthcare system, and therefore, whether it's China or Japan or New Zealand or Scotland or Northern Europe, they're all asking the question, how do we increase value? And that means, let's make sure you stay healthy in your home as opposed to treating you when you're sick. So every society is asking, how do we use the cloud? How do we use mobile? How do we gather data from patients and families and make them an equal partner in their care? Because none of us can afford to spend as much as we spend on healthcare.
That's great. Really appreciate your time, appreciate your effort. Thank you, everyone. Please give a thanks to John.
Thanks so much.
Thanks.
Absolutely. Good to see you.
So we divide up that patient journey into 3 different components. Helps us think about things, and everyone knows it's fun to divide things into 3s. So it starts with acquisition. Outside of healthcare, it's called marketing. And it moves to service. What happens when you're face-to-face with a patient? There's still a role for CRM, for preferences around intake, enrollment, and the experience. And then finally, engagement. As we explode these 3 categories, we see that this patient journey really encompasses a number of other different capabilities, and we've put an assortment up there. So whether it's the acquisition process, which deals with patient marketing, when someone says big data, we talk about segmenting, targeting patients appropriately. Sometimes clinical marketing for those folks that you're already taking care of, to whom you want to tell that you have a new service or a new way of helping them. It extends very quickly to physician referrals and network management. And then as we move to the service, how do you actually engage with a patient when you're taking care of them through a contact center, through case management, home health services, and post-acute support. And then finally, the engagement part. That's what I get really excited about, because it's when people go home that really determines how the outcome is going to be. Are they going to take their medicine? Are they going to do the rehab? Are they going to change their wound dressings? Are they going to have the support that they need from the organization that you might work with, or the organizations that are helping you take care of those patients? We know when I trained as a family doc, we were trained to basically do it all by ourselves. Therapy and all kinds of medicine that we did all by ourselves. And we realize now that nutrition and exercise and reminders and bridging care gaps are not things that even a single individual family doc can do. And so it takes this broad range of capabilities and functions, and frankly, the entire community that we represent to do this work together. And so now it's time. I'd love to sort of share with you and bring up a guest to sort of talk about a subset of some of these things together. So the Cancer Treatment Centers of America are a very well-known, excellent hospital for cancer care, and they use us for physician referrals in the contact center and some patient services. And so now it's really my privilege to bring up Kristen Darby, the CIO of Cancer Treatment Centers of America, to tell us a little bit about how they do what they do with CRM. So please give a warm welcome to Kristen. Let's come up a little closer. Come out into the light. Thank you, Kristen.
Absolutely.
Can you tell us a little bit about Cancer Treatment Centers of America, please?
Yes. Cancer Treatment Centers of America is a national network of 5 hospitals that treat and serve adult patients fighting cancer. The hospitals are consistently ranked among top U.S. hospitals for both clinical quality and patient experience. One of the unique aspects of Cancer Treatment Centers of America is that the majority of our patients self-select us through our direct-to-consumer channel. And in addition to that, we're also a source of information for those seeking information around cancer treatment and cancer in general through our website. CancerCenter.com is the #1 most visited cancer hospital website and #6 most visited hospital website, with over 2.5 million unique visits per month.
That's great. What kind of pressures were you responding to that made you start looking at CRM as a solution?
Well, I think central to Cancer Treatment Center of America's culture, and I think it's reflective of the history of the organization always having a direct-to-consumer intake process, is that the patient has always been central to our culture. Patient is first. And as part of that, we understand that the deeper relationship we have with the patient is going to provide them much more nurturing experience throughout their cancer journey. Cancer is very personable. It's also a life-changing event when you hear that diagnosis. And so it's important to us to have a very deep relationship to treat the whole person, not just the cancer. And so as part of that, we were struggling with our legacy CRM platform to be able to be as agile as we needed to be to react to the changing market conditions in healthcare that are requiring business process changes for us all. But in addition to that, the consumer element and expectations of our patients for how we engage with them and the level and depth of knowledge that we have about each other, but also how they engage with us more from a digital perspective was changing. And so to respond to that, we needed a more modern architecture that allowed us to handle multiple simultaneous changes, be more reactive, be more of a partner. And the Salesforce architecture has actually resulted in a 60% productivity increase for our technical team, which certainly has resulted in a much stronger relationship between IT, the business, and the clinical departments.
It's a really interesting, important point about how these kinds of systems can bring together the organization.
Yes.
So can you describe some of the ways that you're using CRM technologies in your organization right now?
Absolutely. So we're using it in 3 different areas. The first is our physician referral intake process. The second is our 24/7 call center that is staffed by our oncology information specialists that work with individuals seeking information to understand whether or not Cancer Treatment Centers of America is the right location for them to treat. That's also the beginning of the process of building that relationship if they do choose to treat with us. So many of those pieces of information that are very personal, that are shared throughout that process, start to be captured so we can build that relationship. And then the third aspect is around our Cancer Fighters Network. That has enabled us to take what we have built as a grassroots movement around creating a true support network, not only for cancer patients, but also their caregivers. And we've brought it digital through the use of Community Cloud, so that instead of support networks being geographically located around each of our 5 hospitals, we now can expand that at a national level and make sure that patients have the support that they need based on where they are in their journey and what specifically is important to them.
That's cool. It's really cool. You know, I'll ask you the same question I asked to John. There's a broad range of different capabilities, and even the ones that you're describing. Do you have any advice to folks as they look at such a daunting list about knowing where to start, given, as you know, the capital constraints and the technology constraints, and the operational issues that are all wrapped up in these kinds of implementations?
Yep, absolutely. I think the first part is you need to have a vision around the patient experience that's right for your organization. So what do you want to deliver? What type of relationship do you want to have over time? And as you start to get clearer about that vision, which will continue to evolve, within that you can really pick some specific use cases that maybe 1 or 2 that are going to have some specific measurable impact, but also create collaboration between the technologists, the business users, and the clinical users to bring together in a way that deepens the level of service and the connection with the patients that's being delivered. Really, I like the crawl, walk, run approach always, and understand it's a maturity journey. So that vision will help guide you there, but I think those smaller use cases are an easy way to have some quick wins, prove the technology, and also benefit the overall interactions with patients.
And we've seen that also. Thank you very much, Kristen. Everyone, please give a warm thanks to Kristen Darby.
Thank you.
So when we look at this patient journey, Kristen, I think, very eloquently described that you can start at a number of different places and start to augment your systems to create more of that journey. The next story that we'll talk about is a different assortment, but no less effective and no less compelling. And so this is an assortment of home health services, care team collaboration, and patient engagement. The terms are a little bit general, and so to get us a little more detail about exactly what they're doing and how they're doing it, it's really a privilege to bring up John Driscoll, the CEO of WellCare Centrex. Please give him a warm welcome. Thank you, John.
Good to see you.
You know, my voice is a little hoarse, but I'm really thrilled on the inside, even though I'm not showing it as much with this voice.
Well, this is the most exciting part of the entire conference.
Thank you. You're taking that. I'm glad someone has that energy to say that. Tell us a little bit about WellCare Centrex, what you guys do.
Well, WellCare Centrex, we provide services to kind of manage the post-acute journey, if you will, for health plans. We cover about 23 million people. We focus on regional health plans as well as national health plans. And we'll take risk and manage patients from post-discharge to that kind of journey to ideal health. We manage home health, durable medical equipment, home infusion, networks of nursing homes, and we'll also work with hospitals around readmissions and discharge. We're really trying to solve the problem of how do you rationalize a disconnected system to allow it to perform at a higher level, to actually sort of solve the problem that John talked about, which is to bring down costs while improving outcomes. And we think the biggest opportunity to lower costs and improve outcomes is to shift care away from institutions to the home and empower everyone in the care loop to get there.
What kind of pressures were you responding to that made you look to CRM as a potential technology to help you?
Well, I think we weren't necessarily looking for, we were looking for software and intelligence. And with the problem we were trying to solve, a little bit like Kristen was talking about, is what's the ideal state? You know, we have a healthcare system, healthcare really is a team sport, but it's incented in silos, broken down into disconnected by information, lack of collaboration, and lack of effective tools. And so the first thing we were trying to do is how do we get folks to collaborate? How do we provide actionable information? And what tool could we use to actually pull the patient and their family in? And CRM just was the logical step. We very consciously looked outside of healthcare where technology is more rapidly adapting to the needs of the consumer to try to find tools that we could use, because we believe we are under an enormous amount of pressure to deliver on that promise of better outcomes at a lower cost. And the traditional healthcare kind of software kind of development cycle wasn't going to work for us. And so we happened upon CRM and have adapted it and built our own homebridge system on top of that, bringing what we think is the best of outside technology to combine with the tools that we need, and frankly the physicians and nurses and pharmacists need to actually deliver on that promise of allowing people, creating a future where more people can heal and age in the home.
Can you describe a little more specifically now some of the different ways that you're using the technology in your organization?
Sure. I mean, the opportunity with technology is to do kind of all of the hard work in the background so that our caregivers know exactly what that patient and their family's goals are. Because ultimately, personalization is about what does that patient want, and it's goal-driven, and it's contextual. It's making sure that all of the different sources of information, things like pharmacy and meds rec, whether someone needs a particular piece of a particular walker, all is provided to the next most important person in the care loop to make sure they're making the decision. It's basically taking the problem of that we know what to do, but we're not always providing that information to the caregiver or the provider at the time of decision. And so it was trying to solve a problem to make everybody's job easier. It's not really hard to figure out what we should be doing. What's hard is to provide the tools to the providers and the patients at a point of decision.
So people talk about CRM, and we've been talking about this sort of conceptually. Can you describe some of the results that you had? Do you have any results? And I was just going to click the slide, but it's up there, so
okay,
perfect timing.
Well, we've got one particular, the Homebridge technology powers our Homestar program, and for one particular national provider, we had a 40% year-over-year reduction in 90-day readmissions and $88 million savings over 4 years. And what we were really proud of is, in addition to making the payer happy, we have 95% would recommend to a friend. This program reliably has Net Promoter Scores in the 90s because in addition, we got a little bit of a bias for the program because we're getting people home. But the power of the technology is providing a lot of information to everyone across the care journey, to making sure that the patient gets what they need and the family gets what they need when they want, what they need at the time of the next step in the care journey. We're really excited, and we think the Homestar program can provide similar savings and actually patient engagement scores. I was really taken by the point that you started with, which is this is all about the patient. But if we're going to make it about the patient, we've got to make everybody else's job easier. And that's the promise of technology.
I love that you're mentioning the family as a family doc and as someone who sees this all over the place. It's really important that they're a part of it and that they're included. Could you give us a little bit of a demonstration about the technology that you built?
Sure.
Let's switch over to that.
Yeah, let's look at our Homebridge technology. So if you look at this by the way, this is my mother, and it was her birthday yesterday, so Mom is very happy to be here with you. She's 84 years old as of yesterday. We're looking at her at point of discharge. What we want to do is provide, and this is a kind of a traditional kind of pop health screen, but in addition, we've identified what is she really worried about. Well, she wants to go to my nephew's wedding. So we want to make sure that in our Pop Health program, our patient engagement program, that we're thinking about what are the family and the patient's goals. We provided all of the information. It's a complicated situation. She's at the most dangerous point in her care journey. She's sick and she's at the hospital. We want to get her out of that hospital. She's on a couple of meds. She's on a new med. She's had her hip replaced. That's going to require some durable medical equipment, some physical therapy. And we're providing it, though, in a pretty simple one screen, but quick access to the information in the background. We provide this information and through permissions to the family members as well as to the caregiver. Now let's maybe move to the point of discharge. Well, what do we want? How do we empower the caregivers and the decision makers, the discharge planners, and potentially the outside care managers with information that's actionable and helpful? Well, we've got over 100 million Medicare discharges we'll run analytics on, including all of our data, and we'll determine that on a personalized level, what's the best place for her to go through our Homebridge platform, and provide that information to our care manager and to the discharge planner. In the case of Mom, she lives in Massachusetts, so it's Springfield Rehab and Springfield Home Health Care. And behind there, we're running analytics on cost, on complexity, on outcomes, and we're personalizing it to her particular mix of conditions. But we want to provide a clear set of decisions to the care manager at the point of discharge. And as you can see, there's a pretty big range of outcomes, and this is real data for Western Massachusetts. We did this recently. Let's go next to collaboration. So now we've shown you the power of information at the point of decision. We've given you an example of the intelligence that sits behind, because part of our job is the superpowers of technology are to do all the hard work so that the decision maker throughout the care journey can make the right decision. But we also want to make sure that that is pushed out to all the members of the care team. And we see, there's no pharmacist here, but I'm up there. I am, as a sort of a healthcare wonk and someone who is, and as the oldest child, I'm the lead person from the caregiving front. We've got the care coordinator. We'll have her doctor, her care nurse, and the great thing about CRM technology is with the right permissions, we can push out and engage everyone in the care loop, again, solving for that problem that healthcare really is a team sport, but we haven't given folks the tools to work together to deliver the best outcome. Let's move to the next tab. So what kind of information are we going to give? Well, we've actually got to think about what are her goals. Well, for Mom, we've got a certain set of tasks that she needs to worry about, and for the members of the care team, we've also got a number of things we're worried about. And everyone on the care team can work with the doctor, but it may not be the doctor who's the most important. It could be the actual care manager, or it could be me reminding Mom of what she needs to worry about. Let's go through this. So in my cases, I could be actually calling her up and saying, "Hey, Mom, what's going on with your diet? Are you eating? Are you actually keeping that log?" Or one of the great things about leveraging technology outside of healthcare is it provides alternatives. We determined about 6-7 months ago that the Amazon Alexa and a lot of the IoT devices were starting to be used throughout the rest of industry. So why not weave that into what we actually use? For us, we hear a lot about the Internet of Things. We think a lot about the Internet of Care. How do we connect all of the decision makers, all the family members, everybody who cares about doing the right thing? Because it's our view that people in healthcare, a little bit like Josh was talking about, really do want to do the right thing, but are not always provided with the right tools to do that. So let's go, perhaps maybe we just go to the demo.
Great. Well, are we in the demo?
Yeah.
Yeah. Great.
So the cool thing about technology, again, if you believe that technology is about providing power to the individual and creating almost superpowers to be able to see things, have access to things, simplify people's tasks, one of the opportunities is to use Alexa. So, hey Alexa, what are my mom's care plan tasks today?
You have 3 pending tasks. Your tasks are: do not forget to check your blood glucose level today. Begin going on a 10-minute walk daily. Start and keep a daily log of meals.
Simple thing. But what we're creating through technology is defense in depth to make sure that everything that my mom needs, everything our vulnerable patients needs, everybody that vulnerable patient needs that everyone wants to treat as their mother, have the tools and the information to make sure the right thing is done next.
Great. Really cool. Please, ladies and gentlemen, give a great thanks to John. Fantastic. I really like it. So we've seen examples of patient acquisition in CRM. Whew. someone really likes patient acquisition. And service and engagement. And you saw from the demo not only how they do this on a screen in a very conventional way, how they bring other organizations and other individuals in, and also how they're using really state-of-the-art, pioneering technologies to be a part of this. The goals of all of this are the same, and the goals of all of this for all of us are the same: to improve quality of care, to improve the efficiency of all of this, to collaborate across all the organizations, to make this all work together. It's a daunting task. It's a lot of work. But I think we have the technologies, finally, to start really delivering and really fulfilling the promise of all of the work that we do and really wrapping around all of this, all the technology that we have. So really, at this point, we'd really love to get some questions from you. And I'd like to bring up our guests, John and Kristen, to please come up. And really, please, there's microphones at each of the big aisles. Feel free to sort of step up and ask any question that you have.
Don't be shy.
Don't be shy. These are friendly folks. If we can get a mic out, please, for a couple of these folks. Yes, please.
I'll jump up. Elizabeth Regan, University of South Carolina. I've worked in the innovation space for a long time across different industries. My question is, and thank you for the great presentation, and certainly, none of us is from our consumer perspective, or I think from physician provider perspectives would take issue with anything you said and not say, this is the world we would like to have, this is the experience we would like to have. So my question is, why is it taking so long? Why aren't we there if we all agree this is where we want to be? So in your experience, can you comment on what are the barriers you're seeing and our challenges in making it happen? And are there any specific things you might point to as really critical success factors for making it happen?
Why don't we just go down the line?
Oh, sure. Happy to start. So, Josh, I don't know about you, but physicians are sometimes conservative. So I have 18,000 faculty members at Harvard. I call them the 18,000 points of veto, right? So our challenge is, how do you motivate clinicians of all kinds to change? Pay them more, give them a better quality of practice life, or help them avoid public embarrassment, of which the last one you use rarely, but it's very effective. In a value-based world, we are now beginning to publish comparative statistics on quality and total medical expense. I meet with the clinicians and say, in your practice, here's 2 standard deviations. Here's you. Here's the best practice. And they are suddenly saying, oh, you mean I can now learn from my colleagues, I can be paid more, go home earlier, and avoid bad quality scores. So that's the issue. Change management by aligning incentives and by having peer pressure, you can change behavior.
Okay. Anything to add?
Yep. I completely agree with John's description. Just to address your question of why is it taking so long, I think one of the issues is across the U.S., every state seems to be at different levels of maturity in truly embracing value-based care and that transition from fee-for-service. And until those incentives are truly aligned between the experience, the clinical quality that we want to deliver, and the incentives, that's really a challenge. I think most of us that operate in traditional healthcare systems, most of the world is still fee-for-service. And I loved your description of 70% risk. It's fabulous. And when I was in Massachusetts, that level of maturity, I think, is much farther along than many other parts of the country.
John, anything to add?
The only thing I'd add, it is infuriating that we still cost so much and do so poorly by any measure.
Yep.
I mean, we are twice as expensive as the mean, but we're, I think, 50% more expensive than the next most expensive country in the world, which I believe is Norway. We're losing to the Norwegians. I mean, it's embarrassing. I think one of the other cultural things we could do is to adapt some of the techniques of technology where rather than trying to get everything perfect up front, we do more piloting. We do smaller sets of tests. And once we start to see some momentum and success, we create an infrastructure to more rapidly adapt. I mean, if you look at hospitals, health plans, everything in healthcare is set up for long, slow, large, complicated contractual change, even in the context of the the People's Republic of Massachusetts, or the People's Republic of Risk of Massachusetts. And I think we've got to somehow adapt. Why do other industries improve faster? Because they take small risks, learn from them, engage, and then as they improve, they rapidly innovate. We've got to learn more about that and do more of that in the U.S. healthcare system, and we have to do it now because of the demographics.
So we've heard of culture, we've heard of the variability, and we've heard of process change, and they're all really important. The one thing that I'll add that no one has mentioned, or we talked about earlier, is the technology. People have invested hundreds of millions and billions of dollars in systems that really were never designed for these kinds of things. And there's a sunk cost and there's a culture shift that's required to get away from that modality also. Please.
Hi, Pat Rio from the People's Republic of Massachusetts.
We voted for Putin.
First of all, it was great to hear everybody, but I was really interested in WellCare Centrex and working in care planning and just loving the patient story part of care planning. I was so impressed that you talked about a goal that really had nothing to do with lab tests or medical exams. You talked about something really important to that patient's life, your mom, let's say. And I want to compliment you on this. Do you call this a care coordination platform? Do you call it something else?
We honestly try to avoid using any terms from healthcare.
Oh, okay.
Because if you start with Homebridge, we want to get people home, and we really do believe if you don't deal with the whole patient, so not just, and again, I hate the phrase, again, social determinants of health, but really what matters, what's contextual, what's happening locally, if we can address often a lot of the big lifts and easy moves are outside of our terminology and context, but it's deeply personal, and so no, that's woven right in, and that's sort of our kind of patient approach.
Well, you hit me right away with that goal and that patient story and how that, I mean, I just feel like it's left out so often in all kinds of care planning and care, so kudos.
Thank you. Please.
So I'm Kathy Petrosino from Massachusetts, so this is just getting strange. Whoa. It's getting very strange.
I was born in Massachusetts. I was educated.
We're taking over as well.
So I had a couple. I'm with MITRE, and I had a couple questions. One you started to allude to, and that was about there's a lot of investment in EHRs, EMRs, and what is the integration of Salesforce with those, billions of dollars or millions of dollars. The second thing is I have a security and privacy background, as John knows. And when I think of Salesforce as a platform, I don't look at it as, and maybe that's out of ignorance, I don't look at it as a platform that necessarily foundationally has strong privacy and security, I don't know if you call it objectives or, goals. So translating that to an environment where privacy and security are very important, I mean, is this a rebuilt platform for healthcare, or how does that all work?
Why don't we start with the first one? Kristen, you're the closest to the EMR, and then maybe John, you can add to it.
Absolutely. So our platform that we have launched last year on Salesforce is fully HIPAA compliant, has all of the security expectations that you would have of any of your other healthcare applications within your portfolio. In addition to that, we have had great success with integrations and being able to ensure that if we ask a patient at interaction point 1 or 3 or 5 a question, we're able to populate that either to or from the EHR in a way that provides that consistent patient experience that all of us as consumers would desire.
I think all of the CRM platforms have more security than you'd expect, and you can then build on that as you take your CRM platform, and then you build your own kind of box off of that, like in our Homebridge platform. We're hyper focused on that. We serving all these health plans that have been breached. You have to. Anyone in healthcare has to know that they're under attack all the time. And when I was at Medco, we had the Chinese Army banging on our door every day. So that's just. I think there's perhaps more that either is done or you can do. And honestly, most large healthcare organizations are using some form of relationship management software. but with exactly those protections built in, because otherwise you can't show up you're going to lose your job the next day.
So the way our industry is progressing is the recognition by the EHR vendors that they are not going to be everything to all people. And that is, think about it, if it was an iPhone and only Apple made apps, you wouldn't buy iPhones probably. And so what's happened to Epic, Cerner, Meditech, Athena, eClinicalWorks, Allscripts, GE, all these folks have created these FHIR-based stubs so that you can take external third-party products, use a security layer, OAuth, OpenID, and over HTTPS, do get inputs of data in and out of the EHR. I realize that was a lot of acronyms. But the idea being that I believe the ecosystem of the next 2 years will be core transactional systems, we need them for regulatory compliance, et cetera, surrounded by many vendor products getting and putting data to that transactional system. And that's the approach we've taken with CRM.
The only thing I'd add is about the privacy and security stuff, just very briefly. If you look at how these systems were evolved over time, and ours in particular, but many others like us, they were evolved to sequester data from one sales team to another sales team. And they were used for financial services, and they were used for very sophisticated organizations. We sell to the government, we sell to many different organizations that frankly have as high, in some cases higher, levels of scrutiny and security than even healthcare in some cases. And so any of the vendors that are delivering this, to John's point, really take this very seriously. There's never an endpoint, and you can even make arguments about the value and the strength of multi-tenant systems that are focused on software and all this stuff all the time for all of their customers versus some of the on-premise solutions that have different kinds of vulnerabilities. Thank you very much for the question.
So this really isn't a plant, but I think we're all here because we're John groupies.
Oh,
I am as well from Massachusetts.
Good to see you.
Nice to see you, John. But that's not the question. I was actually at a meeting yesterday and was sitting next to a gentleman representing, I think, a 4 or 5 doc practice. And he said one of the things they're doing is they just bought a CRM solution. And I said, great. What do you want to use it for? And there was a very long pause. And I don't want to call him out. I think they're trying to do the right thing. The question really then is, at what point does somebody build their own? Or, you know, what you've done with WellCare Centrex, I think, is a phenomenal solution. It sounds great. I'm sure what you guys have done at your 2 organizations are great, but your organizations that can build product because you can scale. So at what point does the smaller organization say, I got to buy something on the vendor floor versus I'm going to build it myself using a Salesforce type tool?
I'll start. One of my colleagues, an eminent person who's been in software a long time, has this great quote. He says, "Everyone loves V1." Everyone gets excited about that, but when you think about V2 and you think about the years of maintenance and the improvements that you want, it can be very, very expensive. I don't know if I'd recommend really to anyone to build it on their own. Large organizations or small organizations. It's difficult, it's challenging. The security and privacy is obviously something important. You spend so much time just building a foundation that's strong before you can solve the problems that you're really focused on. And so I think buying is almost always better.
Right, and we buy what we can and build what we must. So I think of my role as a CIO as more of the plumber. And that is, I used to provision software in data centers. Today, I procure cloud services and then stitch it together with appropriate plumbing and oversee security.
Yeah.
So even I will eventually get out of the build business.
But I think that the other point, because I completely agree with John's frame, but get started now. I mean, do something. I mean, because one of the problems we need to solve for in healthcare is collaboration, connectivity, and patient engagement. Period. And so even if it's a very light, patient kind of sort of basic contact management system. What's remarkable to me is how many doctor's office, large specialty practices, hospital systems, even within the systems, don't really have. They're still working off of very crude tools, if anything at all. A cell phone and a piece of paper. I would say get started with something now. Build and again, buy what you can and build what you must. But we happen to think that we had to do it because we had to make it easy for everybody in an open API way to kind of collaborate. That was the big problem we were trying to solve. But don't let the best be the enemy of what you could do right now.
Perfect. Thank you.
Winnie Elva-Tingle. I'm from Horizon Blue Cross Blue Shield. I'm not from Massachusetts. I'm a Jersey girl, and
We love
because
Horizon.
because I'm from Jersey, I'm going to talk about bridges. I'm happy you brought up APIs and fire transactions and being able to connect to everybody, right? So it's good that you're building the bridges. The question is, how many people are willing to cross that bridge? In a land where data is the king, possession is 99% of ownership, are all the multiple stakeholders here willing to share the data?
So I can speak on behalf of Cancer Treatment Centers of America, and I think one of the things that is core to our culture is the data belongs to the patient. And what's important to us is how we treat the patient, and we make sure that anyone that we partner with, that's fundamental to the understanding. That data follows that patient. If it needs to go external to our organization, that is fine. And we will make every effort to make it exchangeable in a manner that can be best consumed by anyone as part of that care coordination to make sure that the patient gets the best care possible. So I think up front, you do have to understand from a data perspective how data is going to be used to actually help that patient, the whole patient. So not just necessarily we don't look at things just from cancer, for example. A patient might have significant amounts of comorbidities or other complexities in their home life or other things that affect their overall care. All of those things are captured in a consistent way, and we want to make sure when there's handoffs that everything is wrapped in a manner that most benefits that patient. But I think health systems definitely need to define what's important to them up front when they're making those relationships to ensure that the ownership is kept in the location that's best based on the principles and beliefs of your organization.
And why do we have so much data liquidity in the Northeast? It used to be that a redundant, unnecessary MRI was a profit center. It is now a cost. And so we're seeing competitors sharing data because it's an existential issue. If you don't share data, you can't survive financially.
I do think the world has changed, John. I don't know if you feel the same way, that there's a lot more information available. People understand why it needs to be available across categories. And I think there's a profound understanding that it is the patients. But I do think that's been an accelerating change. It's probably one of the few things that's moving faster than people realize in healthcare.
That's great. I don't think we have any more time for public questions, but feel free to come up afterwards. I really want you all to thank our great guests. They're fantastic at a super high caliber.
Thank you.
Wonderful.